Hi, good morning, everybody, and Happy New Year. This is the 21st edition of the Health System Fix podcast, the first one we are recording in 2026. I am Dr. Gaurav Mishra. I'm a child, adolescent, and adult psychiatrist and health systems design expert. I also want to ask you to please like, subscribe, and share the podcast. Today, we're really excited to welcome two guests. This is our first two guest podcast. Sriram Muralidharan is a co-founder and CEO of Floe Health. Sriram is a builder and has been in the room building real systems. Started his career at Tesla. He helped build the first Model X. Later at Commure, he led enterprise AI initiatives, working at the intersection of the product, AI, and healthcare economics. At Floe Health, Sriram brings the same systems first mentality, helping building infrastructure that can hold up at scale. Anirudh Perubotla is a co-founder and CTO. Anirudh is a product leader. Anirudh is also a Forbes Under 30 honoree and was the founding project manager at Levels FYI. At Commure, Anirudh led the Ambient AI Scribe team. At Floe Health, Anirudh focuses on turning complex healthcare workflows into systems that work in the real world. And their company that they co-founded, Floe Health, is an enterprise AI platform that delivers predictive intelligence, closing the loop on every referral in healthcare. So welcome, guys. I'm really interested in the referral problem. It's a giant gap in our health system, and I've seen firsthand how referrals often just go out into the ether and takes forever for it to come back, if it even comes back in every case. So maybe ask each of you, tell me a little bit about your inspiration to go down this path of developing this organization and product.
Yeah, I mean, I can kick it off, and then we could talk about kind of the personal story and kind of the origin. But really, I think the biggest thing when you look from the data behind referrals and how much it powers healthcare today, nearly a third of all visits, nearly 100 million patients in the U.S. are referral-driven visits, referral-driven healthcare, and 50% of those are falling through the cracks for a multitude of reasons. Right? Like you said, they go out into an ether. Maybe a patient doesn't know, a specialist doesn't know what's going on. And so to us right away, the magnitude of a problem in an evolving system like healthcare just made a lot of sense to go after. That coupled with kind of a personal story that I'll let Sriram talk about kind of really made this the core focus for us.
Yeah, sure. I mean, thanks for having us here, Gaurav. We really appreciate you and Happy New Year to everybody who's listening. Before start with the personal journey, I mean, I work in healthcare AI. I was hit by a drunk person on Lawrence Expressway here in the South Bay. It was what you call a rainy Sunday evening. And I mean, it goes without saying, we in California struggle when there's a little bit of fog and a rain. The guy was drunk. So we hit us about 55, 60 miles an hour. I mean, we got pit by him. And we ended up on the other side of the road. So we had to smash the car open. Everything was like, it was just a sandwich. And it took me probably 3-4 weeks just to get an MRI done. I mean, I had to call, chase someone at every point because my referral was stuck in somebody else's fax queue. When I called my PCP, they were like, oh, it's there. I sent it and the specialist didn't receive it. They had to send it twice. It took me close to 3 months just to get the appointment scheduled and handled. And after that, it took me a year to learn how to walk back again. And so through this journey, I mean, I realized I can't just sit and watch the system fail in front of me working in healthcare AI. We decided to step out and actually build a company which solves real problems.
Yeah, thank you for sharing that. And that's obviously a very tough thing to go through, and the recovery and all of that takes such a long time. But that also tells you how in a health system in the first world, for somebody who has a good health insurance, it is still such a major struggle to get care, even in such a difficult time.
I mean, that's a fair point. I mean, I grew up in India. I mean, over there, I mean, everything I can get done. Like for example, my MRI, I can just get it done in like 24 hours. So again, this something to learn for us when we work in AI from everybody. And one thing, a futuristic system like Singapore or other countries which are coming up in this 21st century, I mean, they're starting with AI first. So what we can do is we can also do AI first here with respect to healthcare. We can kill the fax, replace the fax, go on with like how we can digitize data first and keep it encrypted, safe and everything.
The fax needed to be killed long back. It's frustrating that we still have situations even now that we are at places we use fax. It's kind of the technology that when the world shuts down, then you use, I guess even then you cannot use fax. So it's not even useful in that scenario.
I mean, true that because it started with this concept of if ain't broken, don't fix it. And when we started adopting fax in the 70s, probably the 80s, Correct me if I'm wrong with a decade. When we started adopting that, the focus was on encryption and data safety. I mean, that's why you couldn't open anybody's USPS mail, or you couldn't open encryption. But is fax truly encrypted? Is fax truly safe? What happens if the paper gets lost? Is your referral document shredded? Probably not. There's so many hidden layers to it. So because it's working like reasonably well for them, they're starting to realize. I mean, the first wave of AI companies helped there.
Yeah, I think we can keep talking about facts and its problems. But as you start approaching this, one of the biggest problems is the loop of a referral being placed, the patient getting seen, and that loop being closed with the PCP or the referring provider. How's Floe Health approaching that differently than it's been done before?
Yeah, I mean, our whole premise is how do we turn every sort of referral workflow into a closed loop system? And what are the components that go into that? What are all the different touch points from your Bermuda Triangle of healthcare, right? Your payers, providers, and obviously the patients itself. And so the way we approach it is you always start at the source of where referral comes from, right? Think about there's a visit between a PCP and a patient. The visit happens from there. There's a referral order almost gets generated. If you start there as kind of the top of your circle, and then you go through all the different touch points that a patient goes through, whether it's scheduling automations or just figuring out if it's the right in network, what's the service, how do I get there, all these different parts of it, you'll start to create that circle that comes back to the PCP to make sure they're aligned. So the way we look at it at Floe Health is how do we take that from proactive approach? I know a referral is about to get sent out. Can I determine who it's going to get sent out to? Can I get there before a fax machine would? Can I get all the necessary details I need beforehand? Can I make sure the patient knows what to expect before they even call in or someone calls the patient? All these different things. Can we be proactive? Can we be predictive about it? And obviously that includes a multitude of different kind of Gen AI use cases and actual models that we have, all the way to just basic workflow integrations and what you expect from just a healthcare EMR integration. So that's a high level how we look at it, and then you kind of map the circle and it goes over and over.
I think key point also is like setting expectation both for the patient but also the frontline team who's sending the referral. So right now when you do that, you could have a referral that just goes out and nobody knows when that will actually end up connecting and impacting the patient. That setting expectation is a big gap that I see if this new tool is actually going to make people happy about using it.
Yeah, no, absolutely. You got a point, right? And that goes back to thinking about clinical adoption at scale. How do we make sure that what we're implementing on a PCP side actually helps the specialist side? What we're doing on the specialist side helps PCP. And throughout the whole thing, the patient's got to be happy. They've got to be satisfied. We got to just make sure we deliver outcomes from a clinical standpoint in terms of just patient outcomes, but as well as just from a behavioral psychological standpoint of just satisfaction with care. And so when we talk to a lot of our kind of early customers and a lot of these kind of large scale organizations we work with, one of the main things we do to begin with is we actually go out to the other opposite side or the other end of the circle almost. And so if we're working with some really large specialty organizations or a large health system, we'll actually go out to all the people to get their inbounds from, their inbound referrals, or all the specialists they send their referrals out to. And we go sit with them as well. And we say, hey, what are your problems on your end? Or to basically piece it all together and start connecting it. I think that's one of the things that's worked extremely well for us because we know exactly what the other side expects while we're delivering a product to one end of it. And so that's been helping us drive adoption, but it's also been helping kind of help understand how this whole referral workflow can be rethought and rebuilt from the ground up.
Sorry, Sriram, do you want to add anything to that?
Probably not. I mean, he's on point. I mean, he's the smartest guy between us.
Also, what you're describing, Anirudh, is that you have three customers. You have the PCP and their team, where the patient, but also the receiving referral team. So you really have to satisfy each of those. And again, sometimes, unfortunately, I've seen healthcare implementation being thought about so simplistically. Oh, we'll just fix this one. But then that ends up just being a Band-Aid because you have to think about upflow, downstream, all of that for it to work well. Let me describe a real world problem that I had working someplace. So the PCP send a referral from a mammogram to a different health system. This is all in San Diego. The other health system, mammogram department, the people who will actually do it, don't recognize this PCP's name because that person is not in that system. The second system has to have one of their physicians reorder this. So you already see the clunkiness in the steps. They reorder this. It goes to a mammogram. Let's say mammogram gets done. Sometimes the wait is 6 months in the US, by the way, to get a mammogram done. The report is generated. Who does it go to? It goes to the reordering physician in the second system. And by that point, nobody has a clue who was the original person who ordered it and who needs to see it. So this is like, does Floe Health think about this kind of a clunky system?
I mean, this is a common place with a lot of like inbound radiologists and like specialty organization referrals. So what really happens is the information is not transmitted properly and could be for various different reasons. I mean, could be that they have different EMRs, different like ways of handling a fax, or I mean, for what is worth, the referral could be even a USPS post. We don't know there. But what we do know that, I mean, with Floe Health, we trace the workflow directly and we normalize the workflow before we handle anything. So we are behind every referral, which the specialist handles on their inbound. So what that means is we know what the doctor name is, and quite often it has to relate to their medical number, or could be so many things, which insurance they're coming from. So once the specialists have that information which they need, they probably don't have to create an inbound. They could most likely go ask for more information. So that's how we do it at Floe. And we provide the transparency and the tools to the specialist as well as the PCP to send the right referral the right way, and for the specialist to handle the right referral the right way. So that makes it fairly simplistic and fairly straightforward. And it goes back to what you said. Don't try to recreate a new workflow. Understand the workflow and solve the problems with the workflow which is existing.
Do you find that when you're implementing the technology may be the same, the way you have to implement it in every system is different? Is that what you're finding when you're implementing this solution, or it's very similar across the board?
Yeah, I mean, there's definitely differences. I would say a lot of healthcare, everyone kind of operates a little bit differently. There's a lot of commonalities that we're able to tap into. But for the differences, what we've done is how do we standardize referrals? What does it look like if I was the fax machine today? Floe Health was the fax machine. What does that mean? And then so that's how we kind of approach it. So there's a few differences with even basically the form they fill out for referrals a little different for every site or every sort of provider. Who they go out to is a little bit different. When they send referrals is different. How they handle prior auths is a little different. And so we look at this from our experience in healthcare is how do we build to scale, right? And so when we see these differences, we try to match patterns across them. And so a lot of Floe Health and what's been really working for us these past few months, especially, is the fact that we've built a lot of the infrastructure across the board for these referrals. So even if someone comes in and says, hey, I do things a little different, it's very easy for us to almost pop that in as a module or pop that in as part of the platform itself. And it's not a major task on our end, and obviously it's not a major disruption to the workflow on the provider's end. And so that's how we've taken the whole approach, and that's what's allowed us to kind of scale quickly over these last few months.
One of the things I often see is that the idea is great, but the implementation has not been thought about like it needs to be. Right? I was listening to both your guys' interviews yesterday, and I think Sriram, you mentioned psychological safety for change, and I'm a psychiatrist. And then also you mentioned trust in making sure the flaws are obvious and visible to people. I think, by the way, I've never heard a technology CEO, CTO mention those words ever. So I was actually very happy to hear that, because I think that's really a very thoughtful way of thinking about implementation. I don't know if you want to comment the way you think about that.
I mean, I think being honest, being transparent, we built Floe Health saying we're going to bring transparency to the process. So as founders, there's a part of us we're saying, okay, we have to be transparent with what we're doing with our customers. Yes, it's going to work 90%, the 10% is a partnership. And when you're honest with your customer, they understand. And when you go into a large health system, you say this, but they're more likely to happy to use it. It comes back from our experience. I worked in the airline industry. I worked with Tesla. The first Model X had problems for what you call as the Falcon Wing doors. It's got pivot at 2 points, and so which means this: if you put through a car wash, you're going to get a shower inside the car. And how do you sit and fix it? I mean, every VP, every like SVP was there even Elon was there just to fix it. So that's you. This learning which you trace back to where you started your journey in the industry. So being transparent goes a long way. I mean,
by the way, that what you're saying is very uncommon in healthcare. Being transparent is very uncommon. And this is not by outsiders. Healthcare insiders are not transparent. There's oftentimes executive teams will have these amazing plans, and they'll bring in this new technology and, we'll implement this. We'll spend $20 million on this. Nobody's talked to the front line about what their problems are. So the same clunky system is just replicated in a new technology with the same clunky system. So it doesn't really solve the problems of the front line. So when you have those discussions, how do you make sure the execs you're talking to, yes, they want the new technology, they want things better, they're actually thinking about it a little more like in depth, like you're talking about?
I mean, there's two parts to it. When you start off in the strategic discussions, yes, I can go down to Stanford. I mean, I live a block down from Stanford. I live a block down from El Camino Health. John Muir is around the corner. Yeah, we can have all these conversations, but 80% of all these organizations still have clinics in rural America. Ani and I, we went to what you call this place called Hemet in southern SoCal. Like blazing hot sun, we drove on a mid-afternoon, understood what the problems were. I mean, what does implementation look like? This goes back to what Ani said. I mean, how do you sort of build a system and an infrastructure which can scale from grounds up? And it has to work for 99% of the time. And then the 1% is the accuracy improvement, which you keep doing over and over. I rinse, repeat.
When we're thinking about our name early on, right? Like, what do we want to call ourselves? Do we want to be this like .ai company? Do we want to be a health company? What really was amazing about the name Floe for us was it's not just the referral workflow itself, or just clinical workflows. It's flows across organizations too. What is a admin staff workflow with their providers? What is an exec's workflow with basic dashboard for analytics? What is that exec's workflows with their staff and their providers? So when we say full health, we really mean, across the board, from personnel to actual operations to then the product and the referral aspect of it. That's our kind of goal, right? We make sure everyone's aligned top down, and we've been used to talking to different people and different audiences, and so we kind of know what to tailor there.
When a health exec is not getting it, but he's going to pay your company, how do you get him to get it? Because I've had this problem. So I've tried to solve this problem within healthcare, but how do you, as a service provider, make sure you have to, get them to buy the product, but how do you make sure they're not causing hurdles in your implementation?
I think if you have a good plan, I mean, starts with sports. I played cricket, soccer all my career. So when you start with a game, when you start with, let's say, it's Arsenal, Man City, you're not going to go into Man City and beat them at the Etihad Stadium. Arsenal has to have a plan. So you have a plan and you stick to the pieces of the plan, track the plan, and make sure you execute on the plan properly. Just don't deviate from it. And it comes down to a little bit of common sense implementation, which just be very thorough and detailed. Somewhere in this approach for speed, a lot of folks lost out on how to execute with your end goal at sites. It's like the tunnel view. I mean, there is light at the end of the tunnel. You just don't have to hit it 100 miles an hour. You just go at 65 miles an hour, you will get to the end of the tunnel. So speed does not make sense without good execution.
Yeah, this is music to my ears, because last several years, a lot of my work has been around building behavioral health and addiction medicine programs. And even as a physician within the system, if I try to rush to implement a new program to my own team, who generally likes me, even there, if I rush it, it is not going to get executed well, versus take a very thoughtful, upfront approach and honest approach, not a rose-colored glasses approach, to make sure the team trusts you. The culture of trusting a leader who knows everything and is certain about everything is gone, right? I mean, do you guys agree? Like, you have to be more honest and open today for people, this generation of workers, to actually trust what you say.
Very true. I mean, it goes back to this, what you call is, with generational workers, it's more about ownership. I mean, I can pay the big bucks, I can hire everybody in the valley, but you have to give them the ownership of the process, the product, and the relationships which they're working with. If I'm going to have meetings every day, just to micromanage them, I mean, it's not going to really work. Ani and I are 7-8 years apart, so I'll piss him off if I did that. So that's one part of it. And the second part, quite often we also say this, and we also seek the claim that, okay, we're going to solve. Ani mentioned that there's like 150 billion being lost. I'm going to get all the money back. If I said that, I'm going to be canceled very fast. You have to be like more thoughtful, like 5-10% increments. As you get into increments, the increment compounds very fast.
Going through med school, for me, at that point, thinking about money was like a no. You don't talk about money in healthcare, right? Obviously, everybody wants to make money, but you don't talk about money. It was a very idealistic thing, and it took a while I was practicing and then starting to build programs. I understood the flow of money, how to improve. All of it has to happen at the same time. So let me ask you both about differences in implementation of your ideas and products in other industries versus healthcare. What differences do you see?
Yeah, I think I'll answer part of it. I'll leave the remaining to Ani. The first part in healthcare is the regulatory. With the get-go pitching into enterprise, you already have a bunch of compliance stuff with respect to your SOC 2, high trust, all that regulatory, and data privacy, data security is a very important bar. So, for example, I mean, if I'm selling an app to a consumer and I sell everything and then worry about it later. So there's what you call, and healthcare is a very structured and a well-read crowd. Everybody in healthcare has at least got a master's, probably a doctorate degree. So you have to be very scientific, very data driven about how you pitch your idea and how do you implement your idea as well. Ani, do you want to?
Yeah, I'll add one part to that. I think one of the big things I've noticed is if we take something like, say, a tech compensation platform that we're rolling out to HR departments versus something like Floe Health that we go into a health system with. In healthcare, you almost have to justify your ROI before you can actually justify it with your product. As opposed to in other industries, I can go in and implement and then show the ROI. I think that alters implementation and alters a lot of openness for implementation as well. Something that some exec today might not believe in, which does justify ROI, is something you have to now wait out and you have to convince them, as opposed to in any other industry, I could roll it out pretty quickly, get people on it, get users, and prove that it works very efficiently. And so a lot of those motions start to become very different in healthcare, especially in enterprise healthcare. So when you think about like our go-to-market motions, our implementations, our timelines and pilot phases, a lot of it is driven by, yes, making sure every user is happy with their workflow, everything is intact, but also on, am I justifying that there will be ROI, or can I show a tangible path for ROI for the execs before I actually show them the dollar value they get from this product? And so I think it makes it infinitely harder. I do expect we'll see some changes coming with more and more adoption in AI and kind of more openness to AI solutions, but I think that's one of the main things in healthcare that I've noticed.
Yeah, like well described, because even within healthcare, for a healthcare leader, the way I talk about a new project with my execs and then my team is very different. Like for you, you're fixing the referral pathway, and how you talk about to a PCP or a patient is different than how you talk about to the executive team. And everybody wants the patient to get better, but at the same time, how they measure it may be different, right? So you have to approach it differently.
True. And to your point, I mean, in our conversations, we've seen, I mean, like with an exec, you just have to say, okay, time to care is like proportional to the cost you spend on that. This healthcare is a very cost sensitive industry. And over time, because with rising cost, we have that narrative in place for them so that have those metrics.
It is cost sensitive, but that doesn't stop it from the cost from going up. What I've found is there is more reluctance on, if you tell people we'll save you money, they're not that excited about that. If you tell people we'll make you money, they're a lot more excited about that in healthcare. It's just an observation I've seen over time. Yeah.
I mean, having spent time talking to a bunch of execs in health tech, we got to concur with you on that. We made that messaging too. Making money is better than saving money. I mean, how you thoughtfully pitch it. I mean, there's a learning curve every time you do something.
I know that, both of you are coming from experience with Commure and personal experiences. And I'm thinking of this analogy. It may not be a good analogy, so tell me if it's not. I was thinking that, let's say if I today, as a physician with no IT or coding experience, was say I'm going to build my own AI model, right? And I don't have those very like basic ground level skills or experiences, right? But I'm thinking at big level. If I compare that to how you guys come in and then how you guys hire people, how does this person think about this problem and solution at a very concrete level of a patient experience plan? So you both are obviously driven and you connected to the work, but how do you make sure your team, they're thinking about it very personally as a like a product which is going to impact lives in a very real way? How do you keep that messaging for your own team going?
I mean, I'll answer this in two parts. I mean, qualitatively, majority of our employees have dealt with referrals. Somebody has had a pain, somebody had to be referred to some specialist and they had dealt with. And it's basically this: if your mom approves your company, your company has got a vision. That's how we see it. Our first pitch was to Ani's mom, and then my mom, and then a bunch of our aunts and uncles. You just go into these holiday parties, pitch, hey, this is a great idea. If you hear anything less than I don't understand this idea, you're not going to build that idea. That is not going to work. But the second part, answering your question, anybody can build in healthcare. There's no that doctors can only build, or seasoned enterprise leaders in healthcare are the only ones who can build. Tier 1 people are the only ones who can build. A good example is, Shivrov, a bridge. He's been a great individual. He was quiet for the longest period of time. He's probably got one of the best healthcare companies around in the market. So it's about how you think about a problem, and how you solve the problem, and how do you think about scale. And if you start solving problem only in this room, it probably would not scale to the other room. So think about how you solve the problem in the entire building and then the entire community before you probably want to implement it. And this is where we're seeing a lot more thinking at scale is starting to take place in healthcare as an industry. And I'll leave the qualitative part now.
Instead, from an employee standpoint, it goes back to kind of ownership and transparency. We're not gatekeeping conversations. We're not gatekeeping problems that maybe someone had or feedback. Everyone knows, from your engineers to your CSM to your designers. They understand, for every customer, what do they like, what do they not like, what do we owe them, and kind of what are the learnings from there. And so from a company and team standpoint, everyone understands where we're at in terms of the market, how the marketer looks at us, and how health systems look at us, how providers look at us. And so they're very aligned, and they feel like they're a part of the cause. They're part of the vision. They're part of the mission. They're not just a number or another busy bee just to be kept busy. And so that's one of our big philosophies, right? We really fuel this team with ambition, and we kind of inject passion into them throughout our product building.
That's a great point, because I think in healthcare, sometimes people think that we know the answers. And I think it's really important to partner with people who have different skill set, different perspectives on technology. Even as a clinician, I partnered with our chief financial officer. Let's think about improved financial planning for our services so that we can predict better. So it's not just, we're making more money or saving more money. Yes, but also we are doing more services for the community we're trying to serve. So really thinking about partnering well, and the people who actually can bridge those worlds are probably key. Sometimes you don't have that in an organization, but people who are able to bridge understanding about technology and healthcare or are willing to learn, that helps a lot.
That's a very true point. It goes back to the company culture, what you talk about. Some of my best conversations have always been with my CFOs and the head of finances. Personally, I was very close to Commure CFO. You want to understand different perspectives. You want to foster that open culture of allowing people to have those conversations. And quite often, engineering gets into this silo. You want to prevent those sort of things. If you go into a product or an engineering silo, you're just stuck in that same infinite loop. It just becomes an hamster on a wheel. But if you're open to more conversations, and if you understand, if you thoughtfully process the information, you're already ahead of the game when it comes to solving the problem.
Okay, so what future do you envision for healthcare through Floe Health and also in general? Like, where do you see it going? Where do you want it to go?
Yeah, there's lots of exciting things at Floe Health, and I could, give this crazy dream vision of what I see. But I think for tangible results, Floe Health, a lot of it is how do we rebuild the referral infrastructure entirely across how the system uses it. Like I mentioned, 100 million patients, a third of all visits. What does that look like in this new digital age? Whether it's connected on all ends, patients are informed, there's transparency, we're closing the loop. That's our kind of whole big mission and throughout Floe Health and what we're building towards. And kind of every single provider that steps on, every exec that signs off on us, that's kind of one step closer there. So I think through that process, what I'd love to see is more timely care delivery, just reduce time to care for patients. I think patients being more informed and just obviously delivering better outcomes across the board. And so what I'm personally excited about, I think that's where we've been taking Floe Health. We've been doing for like the last couple of years now. And then I think the next year and this year going forward is going to be very exciting for how we push that. But that's what I'm excited about.
To add to it, iterative and thoughtful innovations will always win in this healthcare market. It's a very well-read, very well data-driven market over any sort of like what you call shooting for the stars and the moons. And that's how healthcare will evolve over time. Healthcare at the end of the day is a deeply integrated service industry. There's a lot of learnings for founders and for leaders across about how other service industries have worked. A good example I can talk about is in the airline industry. When we introduced the Clear, the TSA Pre, everything was manual. Today, you can upload your passport on your Clear app and just go through. I'm from Canada, so I used to work with the CBP, CBSA here across and saw that in real time and also help them understand that I'm not going to replace you. Quite often when I used to cross the land border, does the Face ID replace me? What's the question either of the CBP officers ask? You address that human psychological aspect of it. So that's where iterative innovation really wins in this space.
So, Anirudh, what's the crazy vision you said that you went with the realistic one? Let's hear the way crazy one. By the way, I've heard that if your ideas make smart people think you're crazy, that's a good idea. So go ahead. Let's test.
Yeah, no, I like that. No, I think that the crazy idea at a high level really is how do we essentially almost provide instantaneous access to every part of healthcare to every single stakeholder. A PCP that sits in a visit, would I be able to almost predict that a referral is needed? A prior auth is going to be attached to that referral. I'm going to send a lab order and a prescription, which I already know where the patient is, so that it'll be ready by the time the patient even leaves the clinic or leaves the hospital. And so I think the crazy vision is almost healthcare infrastructure as a whole rather than just referral infrastructure, and making everyone, again, transparent, aligned in the entire system across your stakeholders. So that's the big goal. I think we're far ways away from it. There's a lot that needs to happen to get there for kind of everyone to be aligned, and all the technology has to catch up to get there. But we start bit by bit, right? We're starting with referrals. We'll get to the next step. We'll get to the next step, and so on and so forth.
That's not that crazy, by the way. It's totally needed. And the fact is, I think it's all in the implementation. So it is that's where I see all great ideas falter, where people have this amazing vision, but they're not paying attention to the implementation, like right in front of them. Okay, so maybe a couple other questions I have is how can healthcare leaders be better partners with your organization, with other kind of new innovative products and companies? How do you feel like they could be better partners for you and the industry?
A lot of the big things I kind of mentioned earlier is openness to what these solutions are. Not just us, but like the whole wave of these digital health and healthcare AI companies coming. A lot of us are kind of solving very hard problems, and they're very complex. So I think openness to partner, to co-develop, whatever that looks like for your system and for your organization, but a willingness to say, hey, I'm going to work with this team because it's going to help us drive whatever outcomes, whatever ROI. For us, I think that's the biggest thing, and that's kind of what we've been working with health system leaders too as well, giving them a chance to open up there. I think that's what we've seen a lot, where if you don't have everything solved, then I don't really want you. But if you have everything solved, you're not really tailored for my kind of workflows and use cases either. For us, that's kind of the big thing that I want to see, and I think it's a learning curve for everyone, for us as well.
Yeah, and the willingness to fix it is starting to get up at the percentage of people who are willing to fix things. I think there has to be a little more speed into like how they want to fix it, and it goes back to what Ani said. You're not going to have tailor-made solutions for your organization, and you're going to have to work with big tech companies, small tech companies to try to work with it. This goes back to a psychological aspect too. I mean, my brother is a neurosurgeon. I mean, every time I kind of transfer his iPhone, if it's not fully completely done, tell me when it's completely done. So we have to get over that thought process. Okay, it might not be completely done. You need to do some work.
So you're smarter than a neurosurgeon for some things, for sure, right?
I'm his IT tech support at this point.
So what is the most exciting or challenging problem you guys are working on today at Floe Health?
Yeah, that's a really good question. I would say from a core product standpoint, when you look at a referral is not just one form that gets sent out. It's almost like a packet of materials. And so one of the problems that we've been very focused on is there's a lot of back and forth, because maybe you missed the prior auth and it comes back to the PCP and they say, hey, I need a prior auth for this. Or maybe it was sent to a specialist who maybe is not optimized for that patient. Maybe there's a better specialist. So what we're really, really solving, and especially going into this kind of quarter here in 2026, is how do we build a referral packet immediately instead of just that one referral form? And who needs to be involved in that process, right? Do payers need to be involved? Do we need to get prior auths pre-approved? What does that look like for eligibility style, patients, and kind of having context on the patient? And so it's a challenging problem because there's just so many variabilities and so many variations of it. But our goal is, if we're pretty close to almost standardizing that, such that pretty soon on Floe Health, if you're sending a referral, you're sending everything that goes around a referral, and you'll never have a back and forth. And so it's one of the challenge problems. I think it'll be super rewarding once we kind of officially launch everything there, but that's kind of one of the big ones we've been working on.
I mean, healthcare landscape isn't the same what it was like 5-6 years ago. There is the willingness to adopt, and there's a willingness to think, and the expectation is also very high. Ambient AI is an amazing product. a truly innovation which works at scale. Sure, if you see the sentiment across this mixed. And so as we get into the next generation of AI products which are more closely embedded into these workflows, you'll start to see more the satisfaction factor from like all these health system stakeholders which you talked about. So that is the biggest learning curve across both the founders, both the execs, everybody around in the industry. I mean, if you hear, I mean, somebody will say my scribe is not great. Yeah, I mean, someone will say my scribe is great. Sometimes we just have to think about where we started off and where we are today.
People forget that very quickly, that where they started off. And you're right. I think the openness is definitely there. I'm actually very excited about what new technology, AI, and those technologies can do for both the frontline and the patients. Because I think for patients, a lot of times, despite the amount of money getting spent in our health system, there has been a major gap in how they get services, referrals for sure, but many other parts of healthcare. And the frontline is also really pressured to perform with low resource environment and not enough staffing and not enough technology, or technology implemented without thoughtfulness, right? Something that you guys are trying to do. I think that is hugely lacking. And I'm hoping that this makes democratizing healthcare access easy as you using Uber versus calling a cab at 3 a.m.
I could tell you a story there. So when I first moved here, I was stranded in Madison, Wisconsin. I mean, I went to school in Wisconsin. It was 2 a.m. in the night. There was no taxi. You had to call a green cab or a black cab. I had no phone. I mean, this is like back in the day. Somebody from the student community actually came in and picked me up. So I remember those days. And Uber never showed up to Vancouver until after COVID. So there's a lot of parts of the world where Uber is still what you call as a luxury or a non-existent product. You don't call ride apps. You call Uber. You don't call Lyft. People don't know what is Lyft across the different parts of the world. So that's how synonymous Uber as a product has been. So we want to get there as big tech in healthcare.
And also it's about the convenience, hugely about whose hand does the power lie in. The power needs to shift to the person who's receiving the service, but the power is now in the hands of the consumer.
I mean, over a period of time, it will come to a balance. I can read everything on Google, but I still have to call my oncology friend for any advice on anything. And you still have to call. If I ate junk food, I'm probably sick, I'm not feeling well. You still have to call my doctor friend. I could trust what you call online search platforms and go get a prescription from Costco. Probably that might not work. This is a well-read crowd, so you have to put respect into the process.
My parents believe they got their doctorate when I did mine, and so they just get labs done, and they won't go to see the doctor. I said, no, they only handed out one MBBS degree. They did not hand out 3. So yeah, thank you so much, Sriram and Anirudh. It's a pleasure talking to both of you, and good luck. I know you guys are doing some important work, some difficult work. So good luck, and hopefully keep seeing you progress.
Yeah, perfect.
Thank you so much.
Thank you so much, Gaurav. Thank you so much for having us. Have a nice day.
You too.